Good afternoon. Just so you know, the clock behind you is running about 3 minutes fast, so that way if people have clinical responsibilities, you get 3 minutes of the leeway. My name is Dr. David Dukas, and I'm the Director of the Division of Medical Humanism and Ethics within the Department of Family and Geriatric Medicine. And so it is my distinct pleasure to introduce our speaker. But first, I want to go ahead and give you a brief homage to Dr. James Stambaugh, whose picture is behind me here. Unfortunately, the Stambaugh family was unable to attend today's lecture, but I did want to go ahead and recognize the patient for whom this lecture series is made. And also the other thing I meant to add as a quick commercial. All of our lectures are on iTunes University, usually about 2 to 3 weeks out. You should be able to go ahead and see them, but all of our prior lectures that have been done for the Stambaugh lecture series, the Genes lecture series, and the newer Chang lecture series, going back to February of 2005, are listed on the internet and freely available on iTunes, so you can watch them on your iPod, on your TV at home, whatever you have. So Dr. James Stambaugh, in whose honor this lecture is given, was an outstanding ophthalmologist in Lexington, Kentucky for many years. After completing his undergraduate and medical degree at the University of Louisville, he trained in ophthalmology at the University of Cincinnati. Among the honors he received was election to Alpha Omega Alpha. Dr. Stambaugh's surgical skills were enhanced by his service in the Korean War, an experience he valued for developing his sense of compassion and his willingness to make an extra effort in ministering to his patients. Throughout his career, Dr. Stambaugh always was eager to apply new and innovative technology to his practice while never losing sight of the physical, emotional, and spiritual needs of his patients. He enjoyed teaching and served on the voluntary faculty at the University of Kentucky during the later years of his professional life, which was extended by a heart transplant. Dr. Stambaugh became increasingly concerned about a variety of ethical issues, rapidly occurring changes in medicine, and the impact of societal changes on the medical profession and the welfare of individuals needing care. The Stambaugh family ensures that the ethical issues of importance to Dr. Stambaugh are addressed through their endowment of this lecture series. Our speaker today is Dr. Joel Katz. I know Joel not only professionally through the work that he does, but also personally and as a colleague in the project to rebalance and integrate medical education. The findings of the PRIME conference, which was a national conference held here in Louisville in 2012, are at the Academy for Professionalism in Healthcare, which was founded in the wake of that conference, which you can reach by academy-professionalism.org, where you can see all of our presentations, again, videotaped for your viewing pleasure, as well as our recent 2013 annual meeting. Dr. Katz represented the visual arts in his work at the PRIME conference. Dr. Katz is a graduate of the Johns Hopkins School of Medicine after taking his bachelor's at Burlington College. As a former commercial artist and illustrator, his academic work focuses on innovative methods to improve medical education, including through the observation of fine arts and art education methodology. Today's learning objectives include understanding how training in fine arts is relevant to visual exam and clinical care and patient outcomes. The title today is Can Healthcare Provider Fine Arts Training Improve Patient Outcomes?
Oops, I should, this will be good.
Dr. Katz.
Thank you very much. Those are my 3 kids, by the way, about 10 years ago. Thank you very much, Dr. Dukas, and I do want to thank Dr. Dukas for inviting me and entertaining me and teaching me about all the wonderful things going on at this institution relative to humanities and medical ethics. And I also want to thank the Stambaugh family and their vision for endowing a lectureship that allows us to talk about a topic that's not exactly in the center of the core curriculum at most medical schools. The title that I chose is a little bit ambitious, and I'm going to tell you right out front that I'm not going to I can't achieve the title, but particularly the question of patient outcomes. When we look at a clinical trial in cardiology or in oncology, really the only outcome of interest is patient outcomes. Do patients live longer? Do they have better quality of life? Is it, as cost effective, et cetera? But when we talk about medical education and humanities in particular, there's very little outcomes data of any sort. And to think that we could somehow create an educational intervention that would actually impact patients is hard for some people to grasp. But that is my goal. Ultimately, that is my goal, that anything we do, if it's not going to help the patients, then it's probably not worthwhile. I am very interested in the topic of how do you measure medical interventions and their success, but that's not part of what I'm going to talk about today. If there's any questions at the end, I'm happy to talk about that. And I will mention a few studies along the way, but most of what I'm going to tell you today is a how-to related to what we are doing at our institution. So with that, I am coming right now from Brigham and Women's Hospital, and there's some very beautiful pictures of Brigham and Women's Hospital that I usually include at the beginning to give people an introduction to an institution I'm very proud of. Some of you have probably been there, but the truth is it's a really dilapidated institution where I am. And I had the opportunity to look at these two pictures, and so I joined them together. On the left is the Peter Bent Brigham Hospital when it was opened up exactly 100 years ago, right now, in 1913. It was set up as the teaching hospital for Harvard Medical School. It's exactly adjacent to Harvard Medical School. And it was the first hospital with a full-time academic faculty at the time. It was largely modeled after the Johns Hopkins model. And the very first surgical patient was admitted with hemorrhoids for hemorrhoid surgery. And the first medical patient was admitted actually a month ahead of when they were planning on opening the hospital with typhoid. And there was a big typhoid epidemic going on at the time, so they felt they needed to clear out a room to put these patients in. And these pictures, the hospital was actually not finished being built until a year after it was opened up because they completely ran out of money. And they ended up cutting costs on construction. And so even from the day it opened, it was considered a dilapidated hospital. And the beauty is that this knoll on the left, here, let me see if I have a pointer. The knoll on the left, this construction area was made into a grassy knoll, and over time it was replaced by really hideous looking parking spots. And so recently, through a philanthropic gift, they are now digging a huge hole where they're going to make a new parking lot, and then they're going to return to the grassy knoll of 100 years ago. So that's the institution that I'm very proud of. I'm going to talk a little bit about how art and medicine are related. It's not something a lot of people have ever thought about or heard about. And I'm going to give you some examples of courses that I'm involved in at Harvard where we have faced a problem, and we've thought together about this problem, and we've tried to solve it in a way that gets students of a variety of flavors into the art museum, not simply for the sake of going to the art museum, although that is fun and enjoyable, but rather as a way to address these challenges or problems. I'm going to say a word or two on tips for the museum medical center collaboration. And sometimes when I talk about this, people from the local art museums come. Is there anyone here who's a professional museum educator by chance? I'm not sure it was advertised broadly. But that issue of how do you partner with a museum. And then finally, I'm going to talk about artistic habits that can improve medical care. Abraham Verghese, who's quite outspoken and articulate in this area, said, through the humanities, which he defines as literature, art, theater, and film, we can keep the student's imagination of the suffering of others alive. And the broader area of the humanities is one that I'm very interested in, but my expertise is in the visual arts. And so that's where I'm going to be focusing today. A couple of years ago, actually a year and a half ago now, a number of Harvard faculty members who were trying to figure out how to put this all together, capitalize on our shared interests, and make it easier for the faculty and more accessible for the students, did a survey of our faculty, and it was an email survey, and we actually had a 20% response rate, which is pretty good for that kind of survey. We asked them a variety of topics, but one of the questions was, how many of you actively participate in one of the arts in some way in your life? So I want you to just raise hands here. Raise your hand if you are involved in music, art, literature, film, poetry. Go ahead and raise your hand. So it's pretty similar, interestingly, to the Harvard group, where 85% of the faculty and fellows and students felt that they had a significant commitment to it. Yet almost none of them actually use the arts in their teaching. And then a second question we asked, it's a little bit self-serving, is can medical education be enhanced through the arts? And about 2/3 were confident, either agreed or strongly agreed, that that could be the case. This is a picture of one of our pediatricians, one of our medicine residents, and one of the students performing. So the link goes way back between art and medicine. This is a painting of St. Luke, one of the 4 apostles. He was an artist, he was a painter, and he was a physician. He was Greek. He is said to be the only person to have ever drawn Jesus and Mary from real life, although the historical accuracy of that is in question. And it turns out he is the patron saint of artists, and he is the patron saint of physicians, of both. So there is this kind of overlap exemplified by him. And here he is in a fabulous painting from the 15th century. What are some of the reasons why art is so well suited to medical education? First, they both address universal concerns. They're about life and death and pain and suffering and redemption. I think it's really a very similar sort of palette of interests. They are both simultaneously emotional and intellectual. You can't really evaluate a patient's complaint without understanding their emotional milieu and their feelings at the time, and the same is true of art. It is both can be explained but can be felt. They both transpire over time. They are very much stories, and a headache in a neonate is different than a headache in a teenager, which is different than a headache in a geriatric patient. And that time evolution, the relationship of art and what it means, a 14th century fresco is very different than a 21st century sculpture. They are both inherently ambiguous. And I want to spend a little time on this. I'm going to come back to this issue, is that there's a lot of data emerging that over expenditure, unnecessary testing in medicine is largely related to an inability to manage ambiguity. It's not addressed in the standard curriculum, but when people are unsure, they order a CAT scan. Rather than accept and embrace the ambiguity, try and explain it further, they simply order a CAT scan. And that's part of what I think is unique about art and medicine. And it brings the students, and I use students very broadly. We don't just deal with medical students. We have nurses and social workers and other paraprofessionals we work with, but it brings them out of their comfort zone in the art museum. And in doing so, they escape the preconceptions. They do not have to know the Krebs cycle to participate in a museum session. It distances inhibitions, and it minimizes performance anxiety. So sometimes I see students who were absolutely shy and not saying a word on rounds, and I bring them to the art museum, and suddenly they know the most and they talk the most about artwork. The viewer starts with what they know, and they can always find more in the art museum. And I think that's an important issue, that people don't feel like they need to know something before they start at the art museum, where on the wards and in the classrooms, there's always a sense of guilt. Gee, I should know this. It is multisensory learning in both cases, touch, vision, hearing. And finally, in a more humanistic way, is it narrows the gap, the museum, between bioscience and the human experience. And that is the one of the major challenges in medicine, is how do you train healthcare providers who are both knowledgeable and sensitive or empathetic. Okay. And I'm not sure where this quote came from, but I know where I got it, is from my colleague, Dr. Goffberg. The task of education is to make the strange familiar and the familiar strange, and so too with art. So there's lumpers and splitters in the world, and I tend to think of art in two ways. There are artistic interventions, or art and medicine interventions, museum interventions, that will make the student a better doctor, okay? And that's what they're about, and I'm going to give you one example of that, okay? There are also opportunities at the Art Museum that will make that healthcare provider a better physician. Has very little to do directly with doctoring skills, but more with who they are as people. And I'm going to give you a couple of examples of that. And then finally, there's a large overlap area, and I'm going to give you an example of one that both focuses on physician skills and human sustenance. But people confuse those. So this is where I work. Is there a pointer? Okay, well, we'll just use, you can look up there. This is the Google vision of where Google look at where I work, and you can see that HMS, Harvard Medical School, is adjacent to BWH, Brigham and Women's Hospital. My office is right under the H, very dilapidated, falling apart, leaking ceilings. The Farber is next door, the cancer patients, they're all admitted to the Brigham. They're inpatient services at the Brigham. And 5 blocks away is the Isabel Stewart Gardner Museum, which is a glorious art museum. And 2 blocks further is the Museum of Fine Arts in Boston. And when I give talks like this, people often raise their hand and they say, I'm from X rural community, and we don't have an art museum, or we don't have an art museum that's close. Can you still do the work that I'm going to describe to you? And the answer is absolutely yes. And the reason I included Dana-Farber here is because it's very typical of most academic medical centers is that they have a lovely art collection. Sometimes it's a rotating collection, sometimes it's a personal, ongoing collection, and often it's donated by patients or patients' families. And as an example, we use a methodology I'm going to tell you a little bit about called visual thinking strategies, and we do our training at the art collection in the waiting room at Dana-Farber Cancer Institute. And we could easily do it at the Brigham, although the artwork there is not quite as nice. Okay, so it can be done anywhere. And I was in Milwaukee, and they do something similar to what I'm going to describe to you, one of the sessions, and they do it at a patient's house that has 5 or 6 nice paintings, and that's all you need. Okay, so VTS is one of the methodologies. I'm going to explain what it is, and then I'm going to go past it and not talk about it too much unless there's questions. It was developed by a cognitive psychologist at the Harvard Graduate School of Education named Abigail Husson. And it is a method for teaching art that has transferable values to other fields. So this was developed actually in kindergarten through 8th grade students, and that's principally where the research in this is. And it shows that if you use this methodology, you can enhance, liberate, free their mind so that they do better in math courses, they do better in reading, cognition, they do better in other markers of academic success. So that's the fundamental premise. And it's built on a 3-step facilitated series of questions. First question is, what is happening in this image? So it's an open-ended question asking them to look carefully and say what's going on. You could do it with sculpture, you could do it with painting. And then you have to ask them, the follow-up question is, what makes you say that? What do you see? What's your evidence that that's true, what you just said? So it's evidence-based. And then finally, and this is important, the third follow-up area of questioning is, what else can you see? With the notion that you can always find more. And when I round on the wards and do physical exam, I use exactly the same method. Take a look at this leg. What do you see? Now, I see redness, I see this, I see that. What makes you say that it's cellulitis? What makes you say that it's a bruise? We go through that, and what else can you see? And then they'll look beyond, oh, that melanoma I missed, or whatever it is. So it's a very convenient methodology. It's student-centered. Beginners, you can start where you need to. You don't have to know anything to use it. It provides a safe place for exploration, including of ambiguity, platform for self-reflection, promotes aesthetic development, and that's Dr. Hussein's model is aesthetic development. And finally, it's evidence-based. Okay, and if you want to learn more about VTS, you can go to this website, and most museums, it turns out in the museum educator world, there are a handful of different philosophies about how to teach people about art. This is one of them, but it's not the only method. It happens to be a lot of museums in Boston use this method, so it's convenient. All right, so I'm going to take you through, in the next half hour, 4 problems that we faced and that maybe you guys face. But what I would emphasize is that you can potentially tackle any problem at an art museum in some way, and I'm happy to help you brainstorm on how to do that. So the first one, and this is the one that got me started about 12 years ago, was confidence in and utilization of basic physical exam skills are diminished. Is that true here? Okay, I see some heads nodding affirmatively. Teaching of physical examination skills are done less frequently and less effectively, especially by junior faculty, and clinical habits are formed early in training. So with that in mind, we created a course for first-year medical students called Training the Eye, Improving the Art of Physical Diagnosis. And I should just say that this was based on work done at other institutions, and there's a lot of great work going on at other institutions, but particularly based on a course that had been published at Yale Medical School. And these are some of my collaborators here. And I want to just point out Dr. Shahram Khoshbin, who is a neurologist, he's an oil painter, and he's the co-director of the course. On the second row, those are our 2 professional arts educators. And in the bottom right is Joanna Nash, we've added over the past couple of years, who is herself an artist. And she is from Montreal, Canada, and she teaches chemistry students, engineers, and architecture students how to see at McGill University. That's by teaching them drawing. So we've integrated her into it. Gotha says, what one knows, one sees. So this particular course is, as I mentioned, a preclinical spring elective. And I want to emphasize, some of the courses I'm going to talk about are electives and some are required. This happens to be an elective, so there's certainly a selection bias in who decides to sign up for it. It's limited to 24 students. We usually get about 60 applications out of the 160-member medical school class. And it's an 11-week spring course, Friday afternoons, which is basically the only time that they're not scheduled to do something else that time of year. There are paired observation exercises and didactics, so I'm going to talk to you about a couple of those. We have weekly physical examination rounds, so the faculty take the students in small groups to the bedside and practice exactly the same methods that we're going to do in the museum. We have a fairly new life drawing workshop. There's a VTS workshop, so you can actually become certified as a VTS trainer over 2 days. And then there's some other reading assignments. And I emphasize this in this course and in all the courses I'm going to talk about, is we rely very heavily on our partnership with professional arts educators. The goals of the course are to practice and improve physical diagnostic skills, particularly but not limited to inspection, gain confidence in making unique and important observations, and explore how physical examination affects the process of diagnosis or clinical thinking. Art does not reproduce what we see, rather it makes us see, says Paul Clay. These are the 11 sessions, actually 10 sessions plus the figure drawing workshop. I'll just read through them. Introduction to Visual Literacy, Formal Analysis. Formal analysis is another methodology of decoding art. It's complementary to what we do with VTS. There's a session on color and luminance that focuses on visual acuity and the visual process. Contour, which focuses on thoracic imaging. Lines and symmetry, cranial nerve exam. Patterns and texture, the dermatologic examination. Motion on the neurologic examination, particularly gait. Form, we focus on the respiratory exam. There's a figure drawing workshop, as I said, and finally a putting it all together where we synthesize what's happened over the last 11 weeks. In each session, we'll spend the first hour and a half at the art museum. We'll walk 15 minutes back to the medical school, take a break, and then there will be a didactic session often with patients present, to sort of demonstrate it. So the first session is Introduction to Visual Literacy. Visual literacy is defined as the ability to find meaning in imagery, which for me means the ability to reason physiology and pathophysiology from visual clues. So you see a protruding abdomen, and you start to think, gee, what could that be? Could it be obesity? Could it be splenomegaly? Could it be ascites? And what would be the types of other visual clues that could help you differentiate that, or other physical exam clues? And as an example, we might give this happens to be a photograph by James Elkins, who is an art historian at the University of Chicago. And just take a minute and look at this image. I want you all to take a careful look. And we always ask the students to spend about a minute just gazing at the image. Because we're limited on time, I'm going to do it shorter. But then I'll ask the students, what do they notice here? What do they see? Same questions I told you. What's going on in this image? Does anyone want to be bold and give us an answer? I'm sorry?
Ineffective repairs.
Ineffective repairs. Okay, so good. So, and we ask people to, that's good, that's an interpretation. We ask people to try and hone in on observations, but that is, and what people might say is it cracks. And they look like they might be in the street, and there's the patterns of cracking, and the pattern of patching suggests that it might have been going on for a long time, and you can see the crack going through the curb and extending out into the traffic far away. And James Elkins argues, and I agree, that if you looked at this carefully enough and you were a structural engineer, you could tell exactly what is wrong with that roadway. When it was built, how it was built, what type of traffic and weather it was exposed to, what types of repairs were made, etc. And this is exactly what we do. And you could do the same thing, go through the same exercise with a painting. Again, limited time, so we're not going to do it, but this is one painting that we happen to like and use. And then here's another painting that we like and use. And the interesting thing about these two paintings is they're by the same artist at a different point in his career, Francisco Goya. And they actually have the exact same title, Festival at San Isidro. And one is very lively and bright and festive, and one is very dark and dramatic. And it has to do with what's happened in the 60 years between the two paintings in Spain, the wars that were going on, his own physical health and what happened. He lost his hearing and his vision wasn't very good, etc. So it's a nice opportunity to talk about how things change. And here is one of our graduates of our course. She's actually a dermatologist here, and she's leading this structured observation exercise focused on those same three questions I mentioned to you with the medical students. So that's one session, Introduction to Visual Literacy. Another one I want to focus on is the form and respiratory examination. So again, we start at the museum, and in this case we pick artwork that we think will exercise the part of the brain focused with interpreting and understanding form. And one of the ones we use is a Bodhisattva limestone. And the beauty of this artwork, I'm not sure if you can appreciate it, is it's very tall. It's probably 16 feet tall. From China, and from the side, it is actually a 1-inch thick slab of carved limestone, so it's very thin. Yet the relief is carved in the front, so the entire sense of its power and its activity comes from this relief carving. So as you move around this artwork, and you can walk around it in 360, it changes, the meaning changes dramatically. And also from top to bottom, you can see that there's more detail and more depth in the face and the hand, and then as you get to the bottom, it's simply a very slim relief carving. So that's the type of work we might use. And then we take them back to the class, and here they are. These are some of the students and some of the teachers, and we have 3 or 4 patients who have different respiratory problems. And we prepare the patients in advance, and we ask the students what is going on. And these are first-year students who know nothing about respiratory physiology. They haven't had their respiratory physiology course, but they just make careful observations. Gee, this person's stomach is bulging out when they breathe. This person's voice tapers off quickly. This person has a tube in her mouth, etc. And Dr. Brown, who's in the center with the red tie here, is a pulmonologist and a respiratory physiologist, and he'll take the students through each of those unique observations and show them how that they can figure out which one's got a lower cervical spine paralysis and which one has muscular dystrophy and which one has kyphosis from prior tuberculosis and constrictive lung disease. And then you can see on the back he'll draw it out. So that's this link between seeing and understanding what it all means. And I'm not going to dwell on this, but we did do a study and we did show that people's ability to make accurate observations improved compared to a randomized group of students who had signed up for the course, but there wasn't enough room in the course for them to participate, and that the number of sessions you went to had a cumulative or dose effect, if you will. So the more sessions you went to, the more likely you were to make these accurate observations. There's some limitations, as all studies have. The main limitation is we had a single post-course survey, so we don't have long-term data on its benefit. Okay, so that's problem number one. And each of these problems is with a solution, and each one's very different. And so that's why I'm hoping to expose you to some of the ideas. Second problem, and again, maybe this is just a Boston thing. The rigors of a demanding internship can unwittingly dehumanize otherwise caring physicians. So this is the issue of humanism and empathy. And here it's beautifully captured in this painting by Pablo Picasso in his way, in a very positive way. I think he meant this in the most positive way, that there is the dispassionate, calculating scientific physician taking the pulse and looking not at the patient but at the watch. And then on the left side of the bed is the nun who's holding the patient's hand, and it's meant to show the difference between science and charity. Many people would say the science piece of it has gone way too far. Daryl Kirsch, who's president of the AAMC, has said that in surveys, the public has great confidence in doctors' knowledge, but much less so in their bedside manner. So this is a course that was developed by one of my colleagues, Mariah Quinn, and the two at the bottom are two arts educators at the Museum of Fine Arts, Boston. Barbara, I didn't happen to have a photograph of her. She's very secretive on Google. You can't find her pictures. But they're both very well-trained arts educator, and Mariah and them, with my help, designed this curriculum on humanism and empathy. And these are the professional competencies that are addressed. And it is required. In contrast to the first one, which was elective, this is required for every internal medicine intern at Brigham and Women's Hospital. And it's a longer curriculum, 7 sessions. Each one is a retreat. It's a series of 7 retreats focused on different aspects of humanism. And then each session is with each session is with a senior internist, a psychiatrist, and then in addition, for this one session I'm going to describe to you, is done with an arts educator. The goals are to foster learning about humanistic aspects of medicine, increase a sense of community and diminish isolation, support professional growth, and support personal well-being. And this particular one we do at the Museum of Fine Arts, Boston, right here. Again, there are 7 sessions over the year, but this is the one session that we do at the Art Museum. And I should just say that before the session begins, we have a light supper to bring everybody together, kind of relax people. It's done while they're on their ambulatory block, so we know that their patient care duties will end at 5 or 5:30. They meet at 6:30 at a local restaurant and walk over to the Art Museum, which I said is 10 minutes away. The first exercise is what we call an interpretive challenge, warm-up exercise. What's going on in this image? What do you see that makes you say that, and what else can you see? So same methodology, just kind of loosening people up, getting them used to the museum. We encourage group chatter, shared observations, shared decision making, building on each other's observations, so listening carefully, if you will. And then the facilitators may or may not specifically comment on the role of communication style. And this is a typical painting we might use as a warm-up. This is a fantastic painting by Paul Gauguin, at the MFA. It's called Where Do We Come From, What Are We, and Where Are We Going? This is medicine right here. This is medicine. And it's easily accessible painting. You can't look at it for more than about 12 seconds without having some question that comes to your mind. It's so rich with meaning or implied meaning. So once they've gotten into that, second one is what we call making metaphors. And we break into small groups, and we pick a painting or a sculpture, and I'll show you a few examples of ones we do, and we ask a simple cueing question. How does, for example, this isn't the only one we ask, but this is one of my favorites, how does this piece of art relate to your work in medicine? Okay? Each group discusses that for a half an hour, and then or 15, 20 minutes, and then comes back and then discusses it more broadly with the bigger group together. And so here is a painting by John Singleton Copley. Just take a minute or two and look at this painting and tell me, how does this relate to your work in medicine? I wish there was a way to turn the lights down. I'm not sure if that can be done.
Just in the stage lens.
And this is a rich image. This is, I'm afraid the shadows don't reproduce so well, but this is Watson being attacked by a shark, a great shark in the Bay of Havana in Cuba. And you can imagine the interns, many of them will say they feel like they're these young boys reaching out to save Watson. There are many people who will say they feel like the people in the back of the boat who are sort of helplessly watching carnage and not knowing how to help. There are people who feel like they are the spear holder who is fighting off evil and death. There are definitely people who feel just like Watson, especially in the winter months. And occasionally, but reliably, there are people who feel like they're the shark in this mixture. So it's a rich discussion. And some other images we use, this is another one, a sculpture, modern sculpture. It doesn't have to be figurative art. Again, take a look at this. How does this relate to your life in medicine? People say, this is a series of crystal glasses set up with mirrors so everything looks endless. And they might say, oh, that's the first rule at MI I saw in the emergency room. That's the second one I saw. That's the third one I saw. That's the next one. Or they may feel like they're a piece in a larger operation that seems endless and formidable and inaccessible to them. And this is another sculpture that we sometimes use that gets into issues of patience and nudity and body image. Lots of rich discussions can come out of that. So that's the second activity. Third activity is on difficult conversations. And we always go to a room that has a series of sarcophaguses, one of which I'll show you. And we use that object as a launching point for conversation about death. And how does this image relate to your caring for dying patients? This is a Etruscan sarcophagus, very tender, huge marble piece. And actually, I think it's not marble. It might be limestone. And I would say 4 out of 5 times, people are in tears by the end of this discussion. It's a very revealing image into the patient that didn't make it in the ICU, or the family member, how hostile they were when their loved members were dying, whatever it is. It's a really liberating and powerful experience. And then the last one, we have to cool them off a little bit after that, is on self-care and renewal, and we do a guided relaxation exercise in the Buddhist temple room, which is way in the back of the museum, and nobody ever goes there. It's very peaceful, and this is an example. And by the end of this session, almost everyone is sound asleep. So, and then we have some debriefing at the end, and they answer a few questions. So that's problem number 2, humanism. And again, it's not the only solution to humanism, but it's part of the solution. Problem number 3, physicians are often ineffective in activities requiring collaboration and teamwork, privileging their own point of view, hierarchical relationships, not trained to work in multidisciplinary settings. Duty hours rules and other forces have required restructuring of the academic medical centers to implement and prioritize teamwork, yet we really have very ineffective ways to train people in teamwork. So that's the problem, and this is our third class that we run, and this is required for all of our teams that are on two of our general medicine services. At the Brigham, we have 5 general medicine services. 2 of them are designated as slightly lower workload and more diastolic experience. There's a higher teacher to trainee ratio. The trainees themselves have fewer patients, and it's an area where we consider it sort of a laboratory to really focus on core attributes of doctoring, including this issue. And these are some of the organizers, and I particularly on the bottom right want to point out Ray Williams, who is a very gifted arts educator, was in Boston for many years, recently moved to Texas, Austin, Texas. These are the competencies addressed. And the team, in this case, is all the team. It's the attending physician, 2 attending physicians on the team, a resident, 3 interns, 2 medical students, nurses on the floor, and it's a regionalized care, so you're seeing the same nurses every day, the physical therapist, the ward clerk, the care coordinator, the social worker, they're all invited. In this case, we also provide a nice dinner. It's a slightly nicer dinner because it's not just interns. They're used to actually real food, and I say that tongue-in-cheek. And then we have a little wine ahead of time, which helps attract people as well. And then we all go to the art museum together as a team. The goals are to explore team dynamics, communication style, hierarchy, interdisciplinary relationships, and it's part of a larger curriculum in teamwork that includes orientation on teamwork, professional observation. So our arts educators actually come to the hospital and watch the team around for a couple of days, actually 1 day. And then at the end of the team building night at the museum, which I'm going to tell you about, they give feedback to that team on how what they saw in the hospital and what they saw at the museum. And then finally, we have simulation exercises that are done separately from the museum. So I'm going to tell you about the team building. This is, in this case, we're now at the Harvard Art Museum, which is in Cambridge, short bus ride away. And this is a mixture. On the left is a nurse, a social worker, there's a medical student, 2 residents, and then right in between the 2 guys with the ties, there's a perfect stranger who walked by and is just watching. Okay, so activity number 1, this is, we change it up a little bit, but number 1 is similar to what I mentioned before. It's just sort of a introductory interpretive challenge, okay? And this is a painting at that museum that we like. Again, it's allegorical painting. There's a lot to be seen in this painting, very accessible. Second is an activity, again, we design these to address issues of teamwork. And we pick paintings here that address the issues of hierarchy. What's going on in this painting? What do you see that makes you say that? What else can you see in the painting? And this is a typical painting we use. It's of Pan and Psyche. Take a minute and look at it. It's a rich painting. And you can easily imagine the conversation engendered when you're now having nurses and medical students and interns and attendings talking about this painting, which is simultaneously about sort of a caressing embrace and a fond look of love and a very controlling positioning of the hand. And you can see how people would interpret that differently, and it's just a beautiful entry point into talking about hierarchy. Third might be a creative response as a group and we divide into small groups, and they're assigned a cueing question. So one cueing question might be, who is this person in this painting, and what do you imagine about their lives, okay? And then they write a poem together. And in this case, I'll give you this one because this is one of the ones I like. It's a Rembrandt portrait of an old man. And we ask half the group, now we're down to about 6 people, and it's a mixture of doctors and nurses and other providers. And then half of them have to think and write down, if they were this patient's child, what would they want the healthcare providers to know? And then the other half, if you were the healthcare provider taking care of this patient, what would you want the family to know? And then they each come up with, so that you get 6 short sentences, and then those are arranged into a poem, and then the poem is read to the whole group, as an example. And then the final challenge we pick is one that really tests how a team works together. And what I would call it is a interpretive challenge. And we pick intentionally a piece of art that defies interpretation. So this is a sculpture called I'm With Stupid. And it has recognizable objects and parts, but as a whole, it is impossible to figure out what this is, okay? And the more you look at it, the more confused you get. And this, in the background, is one of our attendings and a medical student and a medical resident, etc., talking about it. And the art educators are watching how they do this, and they're relating this to how they rounded on the teams, on the wards with their patients 3 days before. So we wrap up with reflections, there's a reflective exercise, a writing exercise, and feedback from the arts educator. And these are just some comments that people made. Okay, last problem. High career demands are associated with physician disillusionment and burnout. And this was developed by two of my colleagues that are at the Cambridge Health Alliance, Drs. Goffberg and Ray Williams. And this was principally initially designed for senior physicians, people who are in mid-career or later parts of their lives at a time when people were leaving medicine and there was a lot of dissatisfaction and burnout. But this RIP article is one example of many that show that burnout, or at least the symptoms and the responses we associate with burnout, are highly prevalent among younger physicians and younger medical students as well. Different issue, but this was, and one of the things I like about this, I'm not specifically involved in this one, is it's so simple. All of you could do this afternoon. I'm going to show you how. So here they are, promoting reflection in medical practice, and the citation is in the slides. It was described, I think, in academic medicine. And it gets back to an issue that they call the power of third things, allowing you to approach truth on a slant, that if you ask a direct question, it's harder to answer it. But you can actually get into a much deeper sense of truth by using surrogate questions. Parker Palmer, many of you know, Quaker theologian and educator, talked about things being mediated by a third thing. Truth can emerge from and return to our awareness at whatever pace and depth we are able to handle. Okay, so that the art object becomes this secondary method to get to a deeper truth. And what they do is they write down, they have a shoebox of 30 or 40 prompts. And they give the student, or whoever it is, they pick one prompt out, and then they have to go find an artwork that resonates with them. So two parts. Number one is what's the prompt, and two is what's the artwork. And they spend 5 to 10 minutes with that piece of art, their individual piece of artwork, and then they share their thoughts. And here's a couple examples of prompts. And in their article, they have a lot more details. Find a work of art that speaks to a transition you are experiencing. Okay. Or find an image of a person with whom you have a hard time emphasizing. What is blocking your connection? Okay. And I'm not going to go into more details than that, but it's a really wonderful, simple, half-an-hour exercise. It can be done anywhere, and it doesn't require any preparation, really, other than having that shoebox with the prompts in it. All right, so in the last couple of minutes here, I want to share with you a few things that sort of hopefully tie it together a little bit. The first is this idea of a museum-medical school partnership. When I first moved to Boston, I had no notion that I would ever use art in my medical education. It just didn't occur to me. And one of the deans knew I was an artist and sent some students there. And we eventually made it to the Museum of Fine Arts, and because we were going to try something new. And the arts educators there were thirsty, dying for this kind of thing. They really wanted to do it. They came out of the woodwork. They called me up. They hunted me down because they're very interested in reaching out from what they're doing into a much more practical and far-ranging types of arts education. These are some of the reasons why it works, but all I can tell you is, I will just summarize this slide by saying, if you have any interest, you should go to your art museum. They have arts educators, and my guess is they will make whatever you do much, much better. These are some of the challenges: time, scheduling. Curriculums are already overloaded, obviously. There's not necessarily local expertise, but as you dig deeper, you'll find people who are musicians and are writers and are poets, and they will be willing to help you, and are artists or know a lot about artwork, but it's not necessary. Skeptics are frequent. When we started our program at Harvard, we were actually originally rejected by the Committee on Curriculum and Credits. And what they said is, this is one of the more senior members said, what if this shows up on David Letterman? We are going to be so embarrassed. That was their observation. So there are skeptics. And my advice to that is gather the data, show that it makes a difference. And the piece on that is, it's difficult to get a p-value of the benefit here, although I do have thoughts on that. This is my slide that represents is Rubens' Prometheus getting his liver pecked out. And this is, I feel, how we are as medical educators sometimes. Every good thing we do gets punished. But it grows back the next day. The liver comes back. So finally, my last slide is, I'm going to tell you 10 artistic habits. So I happen to be an artist that can improve medical practice. Number one is careful observation. Make it a habit. It's a little bit, it tortures me sometimes, because when I'm on a bus or an airplane, I'm looking at people's thyroids, I'm looking at people's skin. We were just talking last night about what is my social obligation if I see someone who I think has a melanoma who I just walked by. But it happens all the time. I was in a funeral line the other day, and every person who shook my hand, I couldn't help it but notice something, most of which were benign and not a problem. But it should become a habit. It should become a habit, and it should start early in medical school. Learn to describe what you see. It's not adequate to simply see it, but you have to be able to describe it and share it with your colleagues. Link form to function. So the belly's big. Why is it big? What else? What other clues can I find to tell me that? Avoid preconceptions. There is a sense of accepting at face value what your patients or someone else tells you, and I think it's really important as an educator to teach people to think critically and reassess and avoid accepting other biases. Embrace ambiguity. We talked about that you can have simultaneously multiple right answers coexisting, and you should recognize the tension that causes, but don't be afraid of it. Appreciate context. We talked about that, the difference between a headache in an infant versus a headache in a 90-year-old patient. Think metaphorically, and I think this is a big lesson for medical education in general, is we're all part of a much bigger world, and it's important to think metaphorically. Know yourself as a viewer. So this is one thing we find with the medical students, is that they get anxious about certain things. For example, some people get very disturbed by looking at a sarcophagus, a grave, essentially, casket. Why? What is it about them? What is it about their life that then might be a barrier to them becoming a better physician? And other people will skip over things, very obvious things. Seek partnerships. We talked about that with the museum, but I mean within the class as well, that it's a great way to build community. And then finally, recognize you and your patients' shared humanity. That the art museum, whether or not you're going to learn medicine there, you should visit an art museum, because it's a place to get a sense of how we are similar and how we are different. And art really does address universal questions of life. Gary Berg wrote, "It is precisely because art is so richly complex that our possibilities from learning from it are endless," which I think summarizes it nicely. And Friedrich Nietzsche says, "We have art so that we may not die of reality." So I leave you with those two thoughts, and I'm very happy to entertain questions. Thank you very much.
We have time for questions, and we have microphones on either side of the auditorium. Awesome. Come on down. Come to the microphone.
I realize that you've confined your discussion of art and medicine practice to visual arts, but you also use this as an opening question. You also mentioned literature and music and other arts in your initial slides.
Mhm.
So I'm wondering if you have anything to say about those other arts too, and how one might, well, you don't have to go to a particular
Right.
presentation like this.
Yeah.
How one might use it, especially due to the fact that what is called narrative medicine or narrative ethics is so important now in medical practice.
Thank you for that question. I'm going to repeat the question because I think this is being recorded through a separate microphone. The question is, beyond visual arts, how about some of the other humanities or arts? Do I have any thoughts or comments on how they relate to medical education? The arts that I've seen most frequently and most effectively used in medical education, and in fact way more than visual arts, are literature, reading literature, writing literature, narrative medicine, so-called narrative medicine, poetry, and theatrics. And theatrics in particular, I think, has an incredible, can be incredibly impactful. And each year we actually invite a theatric troupe to come present a portion of a play, usually related to suffering, that leads to an interactive discussion among healthcare providers. And I found that to be particularly moving. Photography can be very powerful, both the photographs about life, photographs about suffering, the patient as a photographer. Sometimes one of our residents got a grant to give all his diabetic patients a camera, a little disposable camera, and had them documenting their life, and then he put that together into a film. And we've had a few residents, this one included, who's a filmmaker and used film to teach about it. So there's lots of opportunities. Dance is another one. It's a little bit more limited, but particularly with movement disorders and disabilities, I think dance and movement can be incredibly powerful. Music, we have a lot of musicians on our staff, and we have a day of musical festivities where people come and play. We haven't used that so much directly in the curriculum, although I know there are places that in the neurology world link it to hearing as well. And there's a very famous pianist who's a psychiatrist in New York who talks about the link between music and medical care. Thank you for the question. Might be time for one more question.
Thanks for the great presentation. After all, medicine is an art, and docs are not just technicians, so this is good. How many years have you been doing this?
Good. I started formally doing this in 2002, so 11 years. The observation class, and it's grown each year.
So, do you have any insight on any generational differences? What I can say is our generation played in the streets. We didn't have computers, so we observed a lot of things. Maybe this is more important today than ever. Not to be a slam on my own kids in school, but
Okay. Yeah. So thank you very much. Question is on whether I see differences, generational differences. And I definitely do. I don't know how to interpret them, but I definitely do see generational. I think that the students today that I interact with are right now learners. They don't have to memorize long differentials because they know where to look them up. And that makes total sense. People of my generation are less familiar with that and less facile with that. One exercise I'll just give you as an example is that we used to do 10 or 11 years ago is we would have the students take off their watch and put it in their pocket. And then we'd ask them to draw their watch on a piece of paper, hand it out. And this is something they look at 20 times a day for 10 years. So they've looked at this watch 80,000 times, and they can't get the details right. Now when we do that, they say, what's a watch? Nobody wears a watch. So then we say, take out your iPhone. iPhones are much easier. You can put it in your pocket. They're much easier to draw. So there are definitely intergenerational challenges. I'm not sure I have any data or any systematic way to know what it all means. But yeah, I think it certainly suggests that we need to have better ways to teach people of multiple learning styles.
Quick last question.
How do you include religion in the humanities or positions?
Yeah, so the question is how to include religion in the humanities. And religion, I'm a big believer in asking every patient about their spirituality and their religion, if that is part of their spirituality. Sometimes it is, sometimes it isn't. And I do teach the residents that's important. I guess I view history and religion a little different than I do the humanities, in the sense that they're disciplines unto themselves, and I have, other than being keenly aware of and probing into and sensitive to that as part of their presentation and their story, I've never used it as a teaching tool in and of itself. But I think I'm sure you could, but I'm just not, I don't know enough about it to be able to answer it. I have found over time that you have some patients, it's very hard to access their emotional core until you ask them about their religion. And suddenly they light up and they tell you about their own experience, whatever it is, and then suddenly you've gained their trust. So I know it's an important part of the therapeutic alliance for many patients, but I haven't used it as a teaching tool.
Thank you very much, Dr.
Thank you very much.